Welcome. Good afternoon. Such a lovely day in Washington for health reform, don't you think? But I do want to thank you all for coming. My name is Len Nichols, and I direct the Health Policy Program at the New America Foundation. And I am about as excited as I think I've ever been to be here today to announce the beginning of Health CEOs for Health Reform, a diverse coalition of healthcare leaders to basically represent a new voice in the health reform conversation. In our view, this initiative is unique because each and every one of its members believes three things. Health reform is so important, we have to have a profound sense of urgency. We cannot wait. We cannot reform our healthcare system unless we change business as usual. And each of them is willing to engage and talk about how to change business models so that we can make a system that will work for all Americans. Over the coming months, our group, Health CEOs for Health Reform, will think about possible solutions to some of the toughest problems in the health reform conversation. Through their vision and their willingness to work across healthcare sectors, as you'll see when we introduce them, these health leaders will seek to reconcile the priorities of lawmakers with the operational realities of our healthcare system. Now, we have a packed and technologically diverse agenda today. We have 7 different speakers in 3 different cities. So I will stop my remarks here. But just to give you a sense of how the flow is going to go, I'm going to introduce each one of the speakers, who will then give a short statement, either through a video recording, which will show up here, a live video feed, which will be to my right, or to a live statement here in this room, and then we'll open it up for Q&A. So before I introduce the first tape we're going to show, I want to thank Senators Baucus and Kennedy for their press statements today, welcoming and initiating our group into the policy conversation. We look forward to working with them, and they look forward to working with our group here in thinking about health system reform. The first speaker we're going to have is a tape from Senator Sheldon Whitehouse, a Democrat from Rhode Island. Some of you know him quite well because in a very short time, his first term, he has made healthcare reform, specifically issues of quality and delivery system reform, a centerpiece of his career in the U.S. Senate. While he could not be here today, he definitely wanted to participate, and we're very happy to show his remarks via videotape.
Good afternoon. I'm sorry that I can't be with you in person, but I wanted to let you know how excited I am that you've come together to address one of our most pressing national priorities, the need for comprehensive health care reform in America. We all feel the incredible momentum behind health care reform right now. For the first time in many years, we have the chance to harness that energy into creating a system that is efficient, effective, patient-centered, and delivers high-quality care at reasonable cost. But as everyone here knows, serious health reform requires more than finance and access reforms. It means fundamental change to the way health care is delivered in this country, including improvements to our health information technology infrastructure, changes in the way we pay for care, a mechanism to compare effectiveness of treatments, creation of a national wellness and prevention strategy, relentless focus on quality improvement, and of course, affordable, comprehensive coverage for every American. And it's vital that we work together towards these goals, that leaders from all areas of the healthcare sector come together to share ideas and come up with concrete solutions. That's why I'm so excited about Health CEOs for Health Reform, and I thank you for your participation. And I thank Len Nichols and the New America Foundation for putting this group together. I look forward to working together on health reform under a new Congress and new administration. Thank you.
Thank you, Senator Whitehouse. So next I would like to introduce Bruce Bedocken. He's the chairman and CEO of Blue Shield of California. Bruce and Blue Shield have been a courageous and pioneer voice calling for insurance market reforms far ahead of their time. And Bruce himself was a key leader during the health reform debate in California. So we are very happy to welcome Bruce again to Washington.
Good afternoon. I'm sorry I couldn't be with you in person today, but I'm pleased to be part of this new group, which I believe will add an important voice of support for the transformation of our national healthcare system. It's It's time for health industry CEOs to step up and say what has to be said, that achieving coverage for all will require each of us to change the way we do business. With regard to health plans, that means giving up the right to pick and choose our customers based on how healthy they are. For Blue Shield of California, healthcare reform, in particular achieving universal coverage, has been a top priority since 2002, when we proposed a plan to cover all Californians. The proposal, which we call universal coverage, universal responsibility, contained many of the same elements that are part of the national reform discussion today. An individual and employer mandate, strengthened public programs, subsidies for those who need them, and guaranteed coverage regardless of health status. Our proposal was similar to the Massachusetts Universal Coverage Plan enacted in 2006 and the California health reform legislation proposed by Governor Schwarzenegger in 2007. While the California bill did not pass, the year-long effort provided an opportunity for all stakeholders to work out solutions to the complex issues that arise in connection with comprehensive reform. We played an active role in that effort and look forward to bringing those same ideas to Washington next year. And it must happen next year. We simply can't afford to wait any longer. 70 million Americans are uninsured or have inadequate coverage. Many of them go without basic care, and nearly 20,000 die early every year. We spend more than $2 trillion annually on health care, but lag behind many countries on quality measures. As President-elect Obama has said, access to good health care is a right. It can't be a privilege reserved for the wealthy and healthy. Fortunately, the stars seem to be aligned. Senator Daschle is an outstanding choice to lead the administration's health reform efforts. Congressional leaders have presented thoughtful plans to cover everyone while improving quality and reining in costs. And healthcare stakeholders across the spectrum, labor, business, medical providers, and insurers are all sounding the call for reform. If we each bring a spirit of compromise and a willingness to give up something we previously held dear, we stand an excellent chance of succeeding. I want to thank my colleagues for their participation in this important effort, and also Len Nichols and the New America Foundation for the great work they're doing on so many fronts to help make healthcare accessible and affordable for all Americans. I look forward to answering any questions you may have.
Thanks, Bruce. And now for the last of our take videos, I want to welcome Lloyd Dean, the President and CEO of Catholic Healthcare West. Catholic Healthcare West is the 8th largest hospital system in the nation and the largest not-for-profit hospital provider in California. And Catholic Healthcare West was also a leader of the California health reform effort. And so we're very grateful to have Lloyd Dean as part of this initiative.
Hello, this is Lloyd Dean, President and CEO of Catholic Healthcare West. I am pleased today to join with my industry colleagues in the New America Foundation in support of providing high-quality, affordable health care for all. Given today's difficult economic times and the staggering increases in job losses and disappearing insurance benefits, the need for health care reform is more urgent than ever. It is time for hospitals and physicians to address the reality that healthcare costs too much. Our current ways of financing and delivering healthcare are outdated and not sustainable. Hospitals and providers should be paid according to the level of the quality they provide and should not be paid for serious mistakes that could have been prevented in the first place. As providers, we must be held accountable for the quality and the affordability of the care we deliver. We can begin by using the tools available to us today, such as the electronic medical record and other forms of technology that can help us achieve greater efficiencies. Today, we have the ability through technology to connect hospitals and physician offices throughout this country and improve care, reduce medication errors, and save billions of dollars a year. Reforming our system will take a momentous effort. All of us must come together. Providers, physicians, insurers, employers, labor and government entities, and be willing to take risks, create partnerships, and innovate to improve the way we care for people. Catholic Healthcare West has long advocated for those who have nowhere else to turn. We support healthcare reform that results in universal access, improved quality, stable financing, and across-the-board accountability. Last year, we worked closely with California Governor Arnold Schwarzenegger and key stakeholders with a broad coalition that included labor, business, and consumer groups, as well as providers and health plans such as Blue Shield, to support healthcare reform legislation. We saw the potential when public and private organizations come to the table. We saw the power of partnership and collaboration. Beginning today, members of the Health CEOs for Health Reform will partner with others who share our vision to make healthcare reform a reality. We believe the nation is ready for comprehensive healthcare reform. This is a time of rare challenge and of equally rare opportunity. We must seize it.
Very good. Up next, we have Dr. Gary Kaplan from Virginia Mason Medical Center in Seattle, Washington. Virginia Mason Medical Center is a nonprofit, comprehensive regional healthcare system that combines a primary and specialty care group practice of more than 480 physicians with a 336-bed acute care hospital in Seattle. Gary has also personally been a leader in thinking strategically about payment reform, which I think we can all agree is a central component of the health reform conversation. Gary.
Thank you very much, and good afternoon. It's a pleasure to be here with other CEOs of the New America Foundation to hopefully help make a difference and contribute to the very important conversation that I believe is about to take place in this country at a magnitude that's never been had before. It seems to me that healthcare reform can no longer be set aside. Change is needed, and change is needed now. Some would say that given the state of our economy, we cannot afford healthcare reform. But I think now increasingly most would say, given the state of our economy, we cannot afford not to have healthcare reform. It's clear to all of us that we have a crisis. We have a crisis in coverage, affordability, and quality. And as proud as I am as a clinician, and I still see patients, although not as many as I used to, but as proud as I am of American medicine, we can be a whole lot better. And we cannot continue to tolerate a 3 or 4% defect rate that no other industry would ever tolerate. And the fact of the matter is it doesn't have to be that way. We're not getting what we pay for. 16 to 17% of GDP, 29th in the world in infant mortality, 48th in life expectancy, and 19th out of 19 in preventable deaths, avoiding preventable deaths. Our U.S. healthcare system is fraught with waste. This waste leads to poor quality and excessive costs. Close to 50% of the $2.3 trillion being spent on healthcare in this country is waste, adding no value for patients, and unfortunately sometimes even causing harm. At Virginia Mason Medical Center in Seattle, using our Virginia Mason production system, our management method that is modeled after the Toyota production experience, the Toyota production system, our experience is showing how healthcare can achieve major cost reductions while improving quality and safety. By eliminating the waste, we've seen over and over again improvements in quality, safety, the patient experience, all while reducing costs. This is the case in ambulatory care, inpatient care, facility design, chronic disease management, across the board. In addition, These methods can result in an environment where very dedicated healthcare professionals and all staff can actually do their very best work and create more time, more value-added time with our patients. Patients in our country can get higher quality and safer care at less cost. It requires partnerships like we've not had before. Partnerships with employers, health plans, government, and others to truly achieve what we are discovering is really possible. At Virginia Mason, our work with employers like Starbucks, Costco, Microsoft, Boeing, is yielding breakthrough reductions in cost for those paying the bills. It's yielding better care and quality and faster return to work for patients. And we, unfortunately, in the provider segment, because of the way we're paid, are actually reducing our profitability while improving quality and decreasing costs. I have a very supportive board of directors at Virginia Mason, but they will not allow me to continue to lead our organization to bankruptcy, doing the right thing, reducing costs and improving quality. We need to change the way our payment system works if we truly want to ensure universal coverage, improve quality, and reduce costs. We all need to change our mindsets and commit to this shared agenda: cost, quality, and coverage. It will require delivery system reform and payment reform. We have to stop incentivizing hospitals and physicians to do the wrong thing, to provide non-evidence-based, non-value-added diagnostic and therapeutic interventions. It's an exciting time for our country and for our industry. We've actually seen what's possible, and we're very anxious to share our experiences and to work together to improve care and reduce costs. It isn't easy, but we're ready to roll up our sleeves and make it happen, and the prize is really going to be worth it: quality health care for all Americans that is affordable. Thank you very much.
Thanks, Gary. Now I'm going to turn live to New Jersey to Ken Frazier, the president of Global Human Health for Merck & Company. We're so pleased to have Ken as part of our group, and we welcome his leadership in particular as we think about all the issues related to comparative effectiveness research. There's Ken.
Thank you. Good afternoon. I am pleased to be here with you today at the creation of this new organization of healthcare CEOs dedicated to achieving health reform and system delivery change. Merck is fully committed to support passage of health reform and universal coverage in the next session of Congress. Health reform is far too important to our nation's well-being and our economic health to delay any longer. Like my colleagues here today, Merck supports health reform that builds on the strengths of our public-private financing and delivery systems. We support healthcare reforms that strengthen our uniquely American competitive healthcare system. We believe that enhancing market competition can spur innovation in healthcare delivery, healthcare financing, and healthcare technology that lead to improved patient outcomes and help control unnecessary expenditures in the right way. To that end, Merck can support a range of policies that may be necessary to succeed at health reform based on market competition. Merck supports a requirement that individuals obtain insurance when available and affordable. We support government assistance to enable people with low incomes to purchase that insurance coverage. We can support a requirement that employers provide access to and subsidies for insurance for their employees. We support reforms to the private insurance market to ensure affordable and equitable access to coverage. We can also support changes to the tax code to limit the amount of employer-sponsored insurance costs that is excluded from federal income tax in order to provide market-based incentives for slower growth in healthcare spending and to produce savings that can help fund subsidies for people with low incomes. We support improvements in the healthcare delivery system to align incentives with better health outcomes, improved quality, and better healthcare value. As part of this policy, Merck supports creation of a national comparative effectiveness research effort. We know that health plans want rigorous, evidence-based information that can help them make coverage and payment decisions. We know that physicians and patients want real-world information with which to make individual treatment decisions. We believe that a well-designed national research undertaking can help fill that need. Merck understands that a new focus on comparative effectiveness will likely change the way Merck does business, the products we bring to market, how we bring those products to market, and how we support the value proposition for those products. We understand that this change is needed in our health system. Therefore, we have decided to support it and prepare for it. We also hope to be able to participate in the change process to contribute our experience in clinical trials and outcomes research to support the development of a truly practical and informative research endeavor. I believe that the group we are forming here today can work together to think creatively, realistically, and constructively about ways to reform the delivery system and align incentives around improved outcomes, higher quality, and better value. I would like to thank the New American Foundation, and in particular, Len Nichols, for creating this opportunity. I look forward to collaborating with my colleagues in this new and important effort. Thank you.
Thank you, Ken. Glad to have you on board. We'll be in touch. Hang in there for a little bit more. Okay, now I want to bring to you Nick Wolter, Dr. Nick Wolter, CEO of Billings Clinic in Billings, Montana. Billings is not only a major hospital, it provides physician clinic services in multiple sites. It's also a big physician group. And it manages 7 rural critical access hospitals. And Nick is in particular got my attention because he is an articulate proponent of the idea that we can't reform our healthcare system unless there is profound physician leadership. He provides that leadership, and we look forward to working with him to engender provider leadership across the country. Nick.
Thank you, Len. I think there is obviously a growing amount of momentum around the idea that the time has come for universal access to healthcare in the United States. There are a number of us, though, who know profoundly, deep in our bones, that this must be accompanied by significant changes in the delivery system, and that the fragmented way in which healthcare is currently provided won't be up to the task of providing universal healthcare. We need more integrated systems. We need accountable care organizations. We need virtual systems. We need new forms of governance that allow hospitals and physicians to work more closely together. We need major league payment reform. Some of the payment reform we need is now being initiated in the form of trials and demos. Some of it is being initiated more broadly. This has to do with more accurate pricing, bundling of care across time in ways that we may extend, looking at episodes of care, mini capitation, the development of value-based purchasing. We need administrative simplification to try to help us take some cost out of the system there, comparative effectiveness, as has been mentioned, regulatory relief, so that gain sharing and more cooperation between hospitals and physicians can occur. And we need really more attention to conflict of interest issues, so that some of the ownership and joint ventures, which are largely created to drive volume, are looked at in a more transparent way than has been the case recently. It's said that patients with 3 or 4 chronic conditions will see 14 or 15 specialists in a year. The care of these patients may account for as much as 60 to 70% of the annual health care tab in the Medicare program. Much of this is driven by the fragmentation of the system, by significant geographic variability, where cost of care in one part of the country may be 2 or 3 times as much for the same thing that's done in another part of the country. The importance of what some Mayo Clinic and others, and as Virginia Mason would be an example, the importance of the science of healthcare delivery, looking at how we organize the care so that the organization of care and how it's delivered in a team way goes along with the importance of an individual physician-patient interaction. They will both be needed, but we need to advance the science of healthcare delivery and the organization of healthcare delivery in order to better respond to the challenges that are so large around cost and quality. It is said by some that a field may not very often reform itself from within. There's probably a fair amount of truth to that. But I do believe that there are a growing number of leaders in healthcare, whether it be in my profession or in the hospital world or in the insurance sector or other parts of the healthcare world, who believe that significant transformation will be needed and needs to be accelerated. This involves cultural change. It involves looking at your professional identity. It involves looking at your value system. This is hard. And even with all the payment reform and the other things that we've been talking about here, it will take a significant amount of leadership to address these cultural issues because this change is coming upon us very quickly. And I think part of the reason for this group to come together this afternoon is to step out and say it's time for that leadership. And I believe there are many providing this leadership now and ready to provide more of it as we tackle the opportunities that we have ahead of us over the next year and beyond. Thank you.
Thanks, Nick. And next I would like for us to go live to Denver and Dr. Patricia Gabo, who is the CEO of Denver Health in Denver, Colorado. You may know Denver Health is the Rocky Mountain Region's Level 1 Trauma Center, a safety net hospital, and actually provides an amazing number of elements of the ambulatory emergency systems in the Denver area. Patricia, how are you?
Thank you. I'm really excited to be here this afternoon, even if it isn't exactly sitting with you in Washington. My Italian grandfather had an old saying that not everything bad happens to harm you. And I believe that saying is applicable to the current economic situation that we're facing and how it actually could propel healthcare reform. We all know that American healthcare costs too much, doesn't give us the quality that we pay for or that we deserve, and leaves many millions of Americans without coverage or access. There is a connection between our dysfunctional healthcare system and our current economic situation. In part, because of our dysfunctional healthcare, American corporations are not as competitive as they could be in the global marketplace. Every corporation, large or small, has enormous healthcare expenses, and all of us are feeling it in our pocketbook. It is really time for us as Americans to create a high-performing health system. And when we create this system, it must address at least 4 of the current failures in healthcare now. The first is we must create a cohesive, rational, national health policy that, first of all, defines a floor of care that every American can get. We also need to define the ceiling. We have to be clear about those things that we won't pay for because they provide little or no value. Secondly, we must reform the payment model. We need to get away from fee-for-service. If you have a model that pays for doing more, people will do more. We need a payment model which removes the tremendous administrative complexity which adds cost as well as confusion to our patients and providers. And we need a payment model which provides the appropriate incentives for doing only that care, which adds real value to our patients. Thirdly, we need to reform the delivery model. We need to begin to give care in integrated models where primary care is valued and utilized, where care is coordinated across the continuum of a patient's life and across the continuum of their disease, and a delivery model which effectively uses HIT. Fourthly, we need to lift the regulatory burden from all components of our health system, which is often costly and often not evidence-based. In America, there are models that can help us with this transformation journey. We believe that Denver Health, which is a public safety net, is one such model. 46% of all our patients can't pay us. This year, that will equal $310 million. And yet, with this payer mix, we've been able to invest $300 million into HIT, create state-of-the-art, efficient facilities, and deliver extremely high-quality, preventive, acute, and chronic care to a vulnerable population without ethnic disparity. We need to look at many models as we begin this transformation journey. Transforming American healthcare will not be easy. It is going to take tremendous political vision and courage. It's going to take the willingness of the American people to change, and it's going to take a willingness of all the components of healthcare to change. Many of them are going to have to be willing to accept less profit. That's why it's so exciting today to see CEOs from many diverse components of American healthcare step forward and say, we want to change. We are willing to change. We are willing to do this to create something better for America. Let's not waste this economic crisis that we have been through. Let's use it to finally create a high-performing health system for this nation.
Thank you, Patricia. And now you've seen the leadership I knew was there, and now you see why we're so happy to have this group together. We're going to, for those of you that are on the live feed or here in DC, we'd like to turn to the audience now for questions. I want to ask the audience to please keep your questions related to this initiative and not to hyper-specific policy solutions you might imagine. For those of you on the live feed, I will repeat the question and direct it appropriately. And I'd first like to open up to members of the media. April?
Jim Argentis, AAFP News Now. Want to know where primary care and the patient-centered medical home fits into this new initiative, and how that factors into things.
Why don't we start with Patricia, because she is a lot of primary care there in Denver, and then we'll go to Gary. Patricia, the question was, where does primary care and patient-centered medical home fit into our team?
It fits in very well with the development of delivery systems that are integrated. Primary care is foundational. A medical home for adults must be part of an integrated system because patients who have chronic disease need care that goes beyond primary care. Primary care is critical, but we must also have specialty care and hospitalization available in a seamless continuum as a medical home for adult patients with chronic disease. But primary care and medical homes in an integrated system are foundational to the new delivery model.
Very good. I'm going to turn to Gary next because Gary actually has to catch a plane in about 3 minutes. So we're going to let Gary answer this question. And then if any specific questions want to be directed to Gary, let's do that right away.
Appreciate the special consideration. I would agree with Patricia that the medical home fits very well in this initiative. The medical home is about coordinating care and about the right people doing the right work so that patients with chronic diseases get everything they need, exactly what they need, when they need it, and where they need it. And I think that it's about teamwork, it's about collaboration, it's about skill task alignment, and recognizing that every piece of care is not necessarily best provided by a physician, and that it requires the kind of coordination that I think we're all striving for, and that we in integrated systems have been championing for quite a while.
Specific questions for Kara? Yes, in the back.
Yeah, Annie Johnson, Congressional Quarterly. Your specific, sorry. Annie Johnson, Congressional Quarterly. Mr. Kaplan, your specific situation was of interest to me because you said your own board of directors wasn't going to watch you, put your hospital in bankruptcy. So my question to you is, what do you give up then? Inefficiency across the healthcare system is profitable, let's face it. What are you and other people willing to give up to make these changes?
Well, let me be sure I'm clear. My board is very supportive of the journey we're on at Virginia Mason and of our support of healthcare reform in terms of cost coverage and quality. What we found, using over 8 years now our Virginia Mason production system methods of eliminating waste, is that we actually can take those inefficiencies out, reduce our cost position, and if we change the way we're paid, we can actually be as profitable as we've ever been. But we would be reducing the cost that it takes to provide a unit of service, the cost that it takes to give patients exactly what they need, where they need it, and it would eliminate the incentives to do the wrong thing. We talk about pay for performance, and right now the conventional pay for performance plans provide 1 or 2 or 3% added incentive for doing some specified types of things that it's important that all patients receive. I believe that we're scratching the surface with these types of pay for performance, and that we ought to change our payment system to more value-based payments. And then those of us who are working hard at eliminating waste and only doing what's indicated and evidence-based and value-added for patients will not be paying penalty. And I think that can happen.
Thank you.
Yeah, I think the question is, what are some organizations doing now that you might be considered, what are we trying to do that is a give or that is a sacrifice, if you want to put it that way. And I think there are a number of organizations doing some fairly dramatic things. For example, in the physician group practice demonstration project with CMS, which we are one of 10 participants, a number of organizations are organizing registries of care for high-volume, high-cost disorders, such as congestive heart failure. And what we're finding is when you enroll those patients and manage them aggressively, you can reduce hospitalization by about 40%. It's a fairly expensive program to put together in terms of how these patients are managed. When you reduce hospitalization, you're obviously reducing your revenue significantly, and yet you're providing much higher quality of life for the patients. And there's a significant dollar savings to the healthcare budget generally. And I think for those of us looking at those approaches to the care of complex patients, we see a tremendous opportunity if we could extend that activity nationwide to free up dollars that can be used for universal access and other approaches to healthcare reform.
Thank you.
So it really is about aligning interest in payment reform. Yes, go ahead.
Hi, Matt Tobias with Modern Healthcare, and I have a question. We've been hearing that we've been on the eve of health reform here in Washington, and today we learned about 2 people who are going to be at least leading that effort, and Tom Daschle and Jean Lambert. And I wanted to know if what your thoughts are, if you can go around the panel and get those thoughts on these 2 people, Tom Daschle for HHS Secretary, and Jean is going to be kind of this right-hand person in the White House.
I'll start with Gary because he's got the flag.
Well, some of you know better than I would, but everything I read and hear about Senator Daschle's passion for healthcare reform, for coverage reform, and ensuring that quality and cost are on the table. I'm optimistic. I think that we have, as has been said by several of the speakers, a great window of opportunity right now. But I would encourage us to not keep in mind we have to be thinking systemically. We can't just think about coverage without thinking about cost. And we can't think about coverage and cost without thinking about quality. And I think, fortunately, as Nick has described and others around the country, we are on to ways that we can actually achieve all with the same methods. And the challenge is going to be finding the will. And all sectors of this healthcare economy have to respond, have to be willing to change their minds, change their thinking. And the provider community, I believe, has to and will step up and do its part.
Patricia, I know Senator Dasher was just in Denver, and I heard you spoke at the same meeting, so maybe you have a view on that.
Yes, I think that this is a great choice. Reading Senator Dasher's book and listening to him just recently outline what he believes is necessary, I think aligns very well with what we're talking about, and certainly his knowledge of Congress and his ability to work in the halls of Congress should be a great asset in moving this agenda forward. So I'm excited about that choice.
Great. Somehow I think that's going to be a consensus, so I'm going to move on to the next question. Yes, sir.
Howard Goldstein from Bloomberg News. This question is addressed to Ken Frazier. I'm just curious, you made a comment about comparative effectiveness is going to change the way Merck does business and how you bring products to market and support the value proposition of these products. And I was wondering if you could expand on that. Frankly, what would it look like if you were to do these things differently from the way you do them today?
Well, we have already put into motion changes in our business model. For example, in our development process, to take into consideration information about comparative effectiveness. We do business in markets around the world, many of which are to some degree ahead of the U.S. when it comes to these notions of comparative effectiveness. Our business is based on rigorous clinical data. And so clinical data on comparative effectiveness is just one more way of comparing what our drugs can do compared to other therapies, including other drugs. So as we go forward in developing our drugs, we recognize that it's important for us to demonstrate more than just safety and efficacy. We also have to think about the cost that surrounds the system and to ensure that innovative drugs actually not only bring clinical benefit, but also health economic value. And that's exactly what we're doing.
Very good. Any other questions? Yes, sir. Oh, sorry. Mike's not.
David Michelson, Washington Analysis. I was wondering what your thoughts are on the Baucus white paper and if you think that this is a good proposal for moving forward in this endeavor.
Well, I think that's a great question. Anyone can answer it, but since Nick is from Montana, I'll let him go first.
Fabulous paper. I think there's many very solid recommendations in there. Many of them build on MedPAC recommendations, or at least a number of them do. A committee on which I served for a couple of terms. The financing approach is one that we see in some of the state initiatives like Massachusetts. The thing I would urge, I guess, as we look at that proposal and some of the others that are in play, is that we really do need to move the payment reform aggressively in a direction that recognizes system approaches to healthcare delivery. Building value-based purchasing on silos will not get us as far as we need to go and not nearly as fast as we need to go. And so I think that is a particular area of focus. How do we develop payment reform that can help drive a more organized delivery system, particularly where we need to focus on these high volume and high cost disorders.
Okay. Anyone else want to comment on Senator Baucus and his white paper? Okay, yes, Linda. Harold.
I'll wait for the mic.
Thank you.
Hi, Harold Kuzner with the Center for Science and Public Interest. You know, a lot of the reforms on payment reforms are long-term in terms of payback. Insurance reform, however, is short-term in terms of trying to get everybody insured. My question is do you have people in this coalition, if you look out at your compadres, if you will, in your walk of life, whether it be a hospital or the physicians, they're not all on board, may we say. And so the question becomes, do you see legislative ways in the short term to build these things in that would be universally adapted because they have the force of law? And what would those be?
Who wants to start? Patricia, you might deal with more uninsured than anyone else. Maybe you should go first on this question. Essentially, what's the best way to get everybody covered? Fair?
Well, how to get everybody
Well, certainly we've captured the uninsured market with 46% of our patients being uninsured. But I think we have to be very careful not to fall into the trap that thinking coverage, insurance coverage, is the panacea and the solution. I actually agree with what you've heard from other panelists that if you just do coverage and you don't address the delivery model and you don't address cost, we aren't going to be able to get high quality and we aren't going to be able to afford this. So they actually must be interlinked and interlaced. So I think it's not going to be a straightforward, let's just do coverage. But I do think that right now, in the current crisis, when so many people are losing jobs and insurance, we've seen our uninsured numbers, which were about 24 million a month for the last 3 years, hit 29.8 this last month. And so we do need to do something in the short term. And the usual approach, I think, is to expand Medicaid, to expand CHIP. But when we do those expansions, we need to be thoughtful about what we're going to pay for in those expansions, and that we're going to make certain that these patients are cared for in integrated, high-quality, low-cost providers in order to be able to even do that first step of expanding coverage.
Ken, I noticed you nodding. You want to add anything on the coverage, cost, quality connection?
No, I would just say that I think I agree with many of the other people who've spoken before. It's not just ensuring that coverage and cost of the issues, but also quality and what value we get from various interventions in the system. Our products are often looked at in terms of just their prices, but in reality the question is, what is the value of a particular drug versus alternative kinds of treatment, and what savings are there in the long run? So I just underscore that I agree with everyone in this panel who has said before me that the issue isn't just a question of coverage and cost, it's also quality and value, as well as, I would say, making sure that we have the right incentives for innovation, and that's based on market competition.
Very good. Oh. So we're a low budget thing. They only have one microphone.
Hi, thanks. Alwyn Castle with the Center for Studying How Systems Change, and I have to admit, sitting here, I'm having to borrow that phrase from that great American Yogi Berra, deja vu all over again. When we talk about integrated care, new payment mechanisms, and I'm thinking, didn't we already try that back in the late 80s and early 90s, and wasn't it something called managed care? And man, the wheels came off of that, which had put us back into a place that is probably even worse than where we were before we tried that experiment. And, you know, I would also note that we have representatives here from large multi-specialty physician practices. And that is not the world that is growing out there in America. You know, I don't think there's been a new big multi-specialty practice formed in God knows how long. So what is it that has got you Don Quixotes out there tilting at this windmill that makes you think you can pull it off this time? And how do you bring the patients along?
Well, I think Nick is the way to go here, because Nick actually deals with a fair bit of rural America as well as all the other great systems. So.
Well, yeah, I wasn't thinking of the Yogi Bear analogy, but earlier we were talking about Bill Murray and Groundhog Day. And for those of us interested in health reform, it does seem like when you get up every morning, you're having the same conversation, and maybe that's been going on for a long, long time. But I will say that some things are different now than they were back in the 90s. And what's different now is that the cost issues are much, much larger and really, truly unsustainable. And secondly, the knowledge that we have about where we could do much better in quality and safety is significantly advanced from 10 or 15 years ago. And it's not to say that we don't have some incredibly wonderful things going on in healthcare, because of course we do. And we all have family who had great experiences in our healthcare system. And I get in these conversations and you sometimes forget to say that. But it's very, very clear that there are more organized ways to tackle the complex chronic conditions that will create both improvement in care and very, very likely more efficiency, compared to multiple admissions and readmissions and missed handoffs and drug errors and that sort of thing. There is a substantial amount of information now that if we can do a better job tackling those issues through coordinated care, that we can make a huge difference in the lives of the patients that we serve. And I think there's some other trends going on which are a little bit different as well. There's sort of an underneath the iceberg amount of employment of physicians occurring by hospitals, which I don't have a quantification of that yet, but there's a lot of it happening. There are more physicians interested in being part of organizations because of malpractice costs, the need for IT, the fact that the science of medicine is becoming more complicated, and having colleagues is helpful when you take care of complicated patients. And so the real question this time, compared to the 90s, when the motivations really were around financial and when we become capitated and that sort of thing, the real question this time, which I alluded to in my remarks, is will we have leadership? Will we have the cultural skills to find ways to work together? And I think that's really what we're calling out, because it will take value systems, cultural change, leadership skills, many of the things that were not in very good shape back in the 90s. And I know your organization, and I know you're seeing some of those same problems in the communities that you study, from year to year. But I think things really are different now. I think there's a reasonable chance that we can develop a critical mass of physicians and hospitals and others that need to look at how they do business differently. I hear that both on the hospital and the physician side. It won't happen in some sort of uniform, smooth fashion. It will be, bumpy and difficult, and it's not a 3-year project. My particular clinic and hospital emerged in 1993, and we're still working on things. This is a 10 or a 15-year journey, but when you look at the critical nature of the issues before us, if we can put the right leadership together, the right payment incentives, I think we can find ourselves in a very different place 10 years from now in American healthcare than we are today.
And I can think of no better way to wrap it up in that statement that absolutely sums up everything. What I love is that we've got these people from different sectors, these leaders, willing to stand with Nick and everyone and try to make this happen this time. So thank you all for coming. We're going to pull the plug at 5 o'clock. We're paying by the second apparently for all this. So thank you very much. Goodbye.